Today we're discussing Squats 101, and specifically how to truly master your ability to coach a squat. Now, a squat is most likely a familiar exercise to you and probably one that you coach your patients or clients through on a daily basis. But in this video, we're not necessarily talking about the execution, the setup, things of that nature. Instead, we're really discussing the prerequisites to coaching a squat. For example, understanding normal versus abnormal motions. When should you see internal rotation? When should you see external rotation? Is it good or is it bad if that patient or client's knees are moving in or out? And why? We're really going to dive into the why. And I find that that's an area within the squat that is neglected, and we jump to the setup and the execution and the performance of it, and that's great. But to really maximize our efforts with the performance side, we need to understand the why behind the squat. So we'll never really understand the why or the reason behind our patients' or clients' compensations if we first don't understand normal biomechanics of a squat. I know in the physical therapy world and the personal training world, we tend to gravitate towards the abnormal and the dysfunctional because it might be the very reason that that person is in front of you in the first place. However, we can treat, rehab, program, and train our patients or clients better if we first understand normal. The normal helps us really link the abnormal. It provides the why, and it also provides the roadmap as to what we need to do based off the abnormal motion that we're seeing. So I want to break down normal biomechanics so then we can really start to justify abnormal. Before we go into the normal biomechanics, I want to give credit where credit is due. And that credit goes out to Bill Hartman. So definitely check out his YouTube page, as he's one that's really educated our whole profession on these concepts and made it to more of a familiar idea. The main concept is the lower extremity arc of motion. This is going to be our guiding principle and our backbone to really understand normal squat biomechanics. So let's break it down and then we can go into a little bit more detail. The lower extremity arc of motion is a reciprocating external rotation to internal rotation and back to external rotation, range of motion during hip flexion. What this means is that the body is moving from ER to IR. This is synonymous with the body first needing space, then producing power, and then finding space, and then producing power. And what you really will start to see is that we have this ER, IR reciprocating movement everywhere in the body and really for anything that we do. So as it relates to our squat, we're going to denote three different sections: 0 to 60, 60 to 90, 90 to 120. And within each section, we're going to have an ER, then an IR, then an ER. So this means 0 to 60, we have an ER bias. An ER bias is where the innominate bones are going to move into more of a position of external rotation, flexion, and abduction. The sacrum is going to be in more of a counter-nutated position. These motions come as a pair, so they're always going to be moving like that when they're in the ER bias. Next, we have 60 to 90. 60 to 90 is where we have our IR, or internal rotation bias. This is where we see the innominate bones move into a relative internally rotated position, adducted and extended position. Also, we have sacral nutation occurring. Again, the sacrum nutating is always going to happen when we have innominate bones that are moving into internal rotation. Then lastly, we have 90 to 120. This is where we go back into our ER position, and we're going to be met with that counter-nutated position of the sacrum. So that's normal. So that means from 0 to 60, we should see an ER bias. From 60 to 90, we should see an IR bias. And from 90 to 120, we should see an ER bias. So what does that mean for you as a clinician or a movement professional? So this means that if you're in the greater than 90-degree phase, we expect ER from the pelvis. But a lot of times we'll start to see ER or flexion from the lumbar spine. This is where the whole lumbar spine just caves under. What does this mean? This means that this person cannot achieve ER through the pelvis, and they're having to find alternate routes to do so. This is how we really start to put meaning behind compensations. So what we would need to do in their treatment or their program would be strategies that is going to give them ER capabilities in their higher ranges, 90 to 120, of hip flexion. So that's an example of how we can use normal to justify the abnormal. But I want to back up for a second because everyone is always confused about that 60 to 90 portion, right? We talked about how that's an internally rotated biased position. Again, when we move through these, it's ER, IR, ER. It's motions of the pelvis to allow the femur to move in a straight plane. If someone doesn't have that capability, that's where we start to see the knee valgus occur. That's where we see the pronation or overpronation of the feet occurring. The lower extremities are always going to try to pick up the slack if we don't have the available motion in the pelvis. But back to our 60 to 90. We see this 60 to 90 because we experience repositioning of fibers, specifically muscle fibers, during this portion. For example, the glute med, the glute, and the piriformis are three muscles that really experience this shift from about 60 to 90 degrees. And this shift is that they primarily start as an external rotator, as a lot of us know them to be, but then they shift towards an internally rotated biased position. Why? Well, let's use the piriformis for example. If we think about the piriformis, it comes from the anterior side of the sacrum, comes around and goes onto the anterior side of the femur. So as your patient or client is standing there in their 0 degrees of hip flexion, it's going to pull back. But as they approach this 60-degree mark and really up towards that 90, as you see, the anterior side of the femur is now exposed in that line of pull. So it's still pulling in the same way, but because the position of the femur changed, it's going to start to internally rotate. And this is why when you're at that 90-degree range, a lot of us stretch a piriformis and move it into external rotation. If you think about it, if you weren't aware of it, it's an external rotator. Why would you put it into external rotation at that 90-degree range? Well, it's because it's an internal rotator at that range. As the hip then continues into further hip flexion, it moves and biases more back into that externally rotated position. Now, the glute max and the glute med have the same phenomenon. They really start as an external rotator, but as they go into varying degrees of hip flexion, they start to shift and the fibers pull more into internal rotation, and then they go back into external rotation. So now that we understand what we should see at different ranges of motion of a squat, we can use that information to help guide us when we start to see the extremities doing strange things. One example we already talked about is the femur moving into massive amounts of internal rotation. Now, when do we typically see this? We typically see it at that 60 to 90 degree range. Why? Because that patient or client doesn't have the available motion to do so at the pelvis. So the pelvis is staying in more of a relatively externally rotated position when it should be internally rotating, but they're in that ER position, and with that, they drive into internal rotation of the femur, and this gives us that classic knee valgus look. So to really fix this, it's not putting a band around the knees to drive external rotation. Why? Because they're stuck in external rotation. We essentially are getting them better at that dysfunction. We need to get them to move proximally. We need to get them to be able to internally rotate. We need the piriformis and the glutes to be able to ease up to allow that internal rotation to occur. For specific strategies on that, I encourage you to check out the Performance Redefined course. This is our online course where we go into those specifics, not only teaching the why, but what do we do from there and how do we program that out so that our patient can move through their normal range of motion. So now we better understand the normal biomechanics and how we can use that to justify our abnormal. So the next thing we need to really understand is the proper trajectory of a squat. The trajectory we're looking for is very vertical, very elevator-like. The trajectory that we are not looking for is very escalator or hinge-like. Now, I don't want to say never because there's certain times for certain people that need modifications that may change the trajectory. The bottom line is if you're aware that you are changing the trajectory, then it's perfectly fine. But the ideal scenario for normal biomechanics, normal range of motion, to get the muscles we're looking to work, we are trying to move in a very vertical fashion. So how does this help you when you're watching someone squat? Well, we already talked about how the femurs can move into various motions to try to find the motion of the pelvis. The other thing that the body can do is we can just move the entire pelvis. So when someone's going down for a squat, if they don't have that available internal rotation, they can start to hinge back. This is going to help bias them into a position where they can pick up a little bit of internal rotation. Now, if we're deadlifting or doing a hinge-based exercise, that hinge or that escalator is great. But when you are squatting, we are trying to keep that vertical trajectory. So I want you to really think and ask yourself, the next time you're coaching a squat, does your patient or client move like an elevator? And if they move like an elevator, but then start to hinge or change the trajectory, at what point are they doing it? And why do you think they're doing it? Chances are they're trying to pick up internal rotation, but what do you see going on? And why do you think that that's occurring? I want you to really understand the normal biomechanics and the trajectory of the squat. These two principles can really help guide you when you're coaching a squat. I find that it's really easy to get caught up in different types of squats and different modifications, but we neglect those foundational principles. The foundational principles are the lower extremity arc of motion. What do we expect to see? And then as our patient or client performs a squat, do we see that expectation? And then what does the trajectory look like? Now, the biomechanics and the trajectory usually go hand in hand, but the trajectory and the biomechanics help you really justify the why behind the compensation that you may be seeing. Now, like I previously said, if this is something that really interests you, if you really want to know more specifics and specific exercises and strategies that you can use with your patients and clients, then I encourage you to check out the Performance Redefined course. It is completely free to get started. It's online and self-paced, so you can learn when it's convenient for you. So again, Performance Redefined, I'll leave the link below, and I hope to see you guys in the course, and I hope this video was valuable to you.